Hi, good afternoon, everybody. My name is Dr. Jessica Collins. I'm a podiatrist with Mercer-Bucks Orthopedics. And today for our webinar, I'm going to talk to you guys about wound care basics. We're going to go over the identification, treatment, and prevention of wounds with a lower extremity focus. So just a discussion outline here. I'm going to give you guys a introduction, and then we'll go over the identification and classification. We'll go over some treatment options and some preventative measures. So I wanted to start out by just letting you guys know what a wound care specialist is. So a wound care specialist is typically a physician, somebody who provides direct patient care. I just highlighted the main bullets here. So the physician or the wound care specialist provides conservative sharp debridements. They provide consultation and follow-up with patients. And what's really important for any wound care specialist is to provide adequate communication, collaboration, and education for patients, and to help develop and be part of a multidisciplinary team. So what is a wound care center? A wound care center is similar to the traditional office setting, but differs in the way that they're managed and the way that they're structured. They can be freestanding or they can be associated with a hospital. And what's different about a wound care center versus just a traditional office is that they focus strictly on the management of wounds, and they have staff that are specifically trained and certified to manage wounds. So just to give you guys a brief introduction of the way our body heals any wound, our body goes through different phases, and they're called the phases of healing. When you have an initial wound, the first step is hemostasis, or stopping bleeding. The next step is the inflammation phase. The inflammation phase is when bleeding is further stopped, and it's a phase that's really important because it does help prevent infection. It's the body's initial response to the wound, the trauma. The next phase is the proliferative phase. In the proliferative phase, this is when our cells make new tissue. The wound starts to contract, and then finally there's what's known as the remodeling phase. The remodeling phase is the final phase, and it's when the wound fully heals and closes. A lot of times when we're differentiating between an acute wound and a chronic wound, which I'm going to go into, we can relate to these phases of healing because chronic wounds get stuck in one of these phases, and typically it is in the inflammatory phase. So like I mentioned, acute versus chronic wounds. An acute wound is typically traumatic or surgical. They tend to heal rapidly and in a predictable manner, and they result in what's called durable closure, or enough tissue to close a wound. Chronic wounds, on the other hand, they're frequently caused by vascular issues, chronic inflammation, or repetitive insult or trauma to tissue. They fail to close in a timely manner or fail to provide enough tissue for closure. A chronic wound can be quoted to heal within or beyond, a 4 to 6 week period. So it depends where you're looking, but typically the literature will tell you a acute wound will heal within 4 to 6 weeks. After you get past the 4 to 6 week mark, you're considered to have a chronic wound. So these are some factors that can affect wound healing. Locally and locally at the area, things that can affect wound healing are oxygenation, so how much oxygen is getting to the tissue, infection, if there's any infection present, if there's any foreign body. So with traumas, sometimes there's a splinter left behind. If you stepped on a needle or some sort of sharp object, glass, then that can be left behind, and that's going to impact healing. Swelling can impact healing, as well as trauma to the area. Your age can impact healing. Your weight, if you're a smoker, if you drink alcohol, and then systemically throughout your body, what can affect wound healing are if you are immune compromised at all, if you had any cardiovascular or any respiratory, any metabolic, any endocrine issues, or if you had any renal or hepatic issues, as well as your nutrition overall. So nutrition is really important in healing. Your protein levels are very important. And so nutritionally, you can definitely impact your healing and any medications that you're on. So just some wound care basics, which is really an overview of what we'll talk about here. Our treatment goals are improving circulation, addressing any comorbidities a patient may have, treating any infection that's in the area, removing any pressure or irritation to a wound, and then dressings that keep the sites clean and dry. So that's your goal with any wound. So wounds can be categorized in many different ways. I listed here the main categories of wounds. So traumatic and surgical wounds, which are, as I mentioned, acute wounds, they tend to heal in a predictable way versus a wound that is considered to be a pressure wound, a venous wound, an arterial wound, or a diabetic wound. These wounds tend to be chronic and they don't heal in that predictive manner. There are other types of wounds out there. There are wounds known as atypical wounds, but for just this basic overview today, this is what we'll be talking about. We'll be focusing on these 4 wounds here. And I wanted to start out by just going over how you identify these wounds. So we'll start with the arterial wounds. They're also known as ischemic wounds. Arterial wounds are associated with peripheral vascular disease or peripheral arterial disease. And what that is it's the blood flow to our lower extremity, to our legs, our feet, our ankles, and there's disease within those arteries. So the arteries become either partially blocked or all the way blocked, and that in turn affects the blood flow or the circulation. The overlying skin and the tissue don't get oxygen because the blood flow is poor. The tissue then dies and the wound then develops. Risk factors include being a diabetic, if you have any foot deformities, wearing poor footwear, obesity, if you have what's called peripheral neuropathy or loss of feeling in the lower extremities, and also having limited joint mobility. So the characteristics of an arterial wound and what help us identify an arterial wound are typically patients say they're very, very painful. They're often found on the foot, the lower leg, or the ankle. They are prone to infection. That's because there's not adequate blood flow getting to the area. So there aren't those good fighting cells that we have getting to the wound to kill bacteria. So infection is very common with arterial wounds. In addition, when you don't have good blood flow, you can imagine any antibiotics you take aren't always reaching that wound site. So again, they are prone to infection. The appearance of the wound is often punched out. You can kind of see based on this cartoon here, the punched out appearance. It can be rounded to the edges as well. These arterial wounds are often very deep. They often extend all the way down to tendons and bones. They frequently have no signs at all that any new tissue is going to grow or is growing. The wound bed, or the way that it appears, is typically yellow, it can be brown, it can be black. A lot of times people have heard of gangrene and have maybe seen pictures of black toes, black tips of fingers. Those are ischemic injuries or ischemic wounds. So the signs and symptoms. So typically there's cooling of the skin. If you were to look at your skin temperature gradient, which is assessing the temperature of your skin starting from, let's say, your knee going down, usually it'll be cool or it'll be warm. And as you get lower into the foot and the toes, it'll be cool to the touch. You typically cannot feel pulses. Usually the skin and the nails are what we call atrophic. There is hair loss. Typically that means the skin takes on a really shiny appearance. It can look dry and thin, but it often looks very taut and shiny in appearance. The legs, they can turn red when they're dangled. And then when elevated, they turn pale. That's because of gravity. When the legs are swung, let's say, off the side of the bed to be hung down, blood rushes to the area, they turn bright red. And that's why you see that skin color change. Oftentimes, one of the early signs is having pain with exercise, and that doesn't mean exercise going to the gym, but just moving, walking. If you can't walk, let's say, from your house to your mailbox without having pain in your legs, that's a really good sign that you need to see a vascular doctor so you can check the blood flow to your legs. A lot of times there is temporary relief of the pain that patients experience by them hanging their legs over, let's say off the side of a chair or off the side of the bed. And that's because that gravity helps blood get down to those tissues that are starving for oxygen. And so you do get some temporary relief when that happens. Here is a picture on the side of several arterial wounds. You can see they have the dark appearance to them. They have these punched out looking borders. You can see a little bit of a closer look here. Typically, arterial or ischemic wounds are very dry. They tend to not be very moist. If there is a lot of moisture to an arterial wound, it's often related to infection. So the next type of wound we're going to talk about is a venous wound, which is also known as a stasis wound. This is the most common type of ulcer that is seen in clinics. Approximately 70% of all leg ulcers that are seen are venous stasis wounds or ulcers. And I should say that ulcer and wound are interchangeable in these cases. They're typically caused by the valves in our veins becoming incompetent or not working. There's a picture down here that shows blood flow. So our arteries bring blood down, our veins bring blood back up to the heart. Typically, there's this one-way door that as our heart contracts and blood flows, blood is pushed through and back up to our heart. However, when you have varicose veins or incompetent veins, veins that aren't working, this door doesn't work anymore. Or it doesn't work as efficiently. So when the blood is pushed up through the wall, it ends up going back down and you get congestion within the veins. Pressure builds up. The legs end up becoming very swollen. You get skin color changes to the legs. You can develop eczema and ultimately ulcers. This can happen because of a lot of different factors. It can happen because of obesity. It can happen because of genetic factors. A lot of times it has to do with having high blood pressure, but it can happen in pregnant women as well. This is a picture that I found to be pretty accurate in describing the stages of developing a varicose ulcer or a venous ulcer. So as I was telling you, the skin can get red and inflamed. You can have some discomfort to the area, but a lot of times you don't feel pain. As the skin becomes more and more inflamed from the swelling and the extra fluid on the legs, you can develop leaking of fluid. You can develop weeping. You develop blisters. And then those blisters pop and you develop wounds. So the characteristics of a venous or a stasis wound, so they're almost always below the knee. They're most often on the inner part of the ankle. That's where a very large vein runs. There's also another large vein on the outside of the ankle. So they're very commonly found around the ankles. They are relatively painless. They take on a punched out or irregular bordered appearance. The wound is typically brown. The skin around the wound is typically brown. The wounds themselves can also have a brown or yellowish appearance, but around the wound, you get this staining of the skin. As you can see here in this picture, you have this kind of pebbled looking outside to the wound there. You have this punched out looking appearance. The wound bed is yellowy, but around is really your key sign here where you can see there's this staining to the skin and you can see some spider veins around the ankle there. This is another picture showing that staining that develops on the skin when you have venous incompetence or veins that aren't working the way that they should be. Ultimately, because the fluid doesn't go up back to the heart like it's supposed to, it stays around the legs. You get staining of the skin because of the red blood cells that remain stagnant and within the tissue. They tend to be very wet and weeping. They tend to also be surrounded by dry, itchy, and like we said, reddened skin. Signs and symptoms of a venous wound, is swelling and aching in the legs. Oftentimes you do experience that late in the day. So unlike the pain that you feel with an arterial wound or an ischemic wound, which is typically all the time, this tends to be more painful at the end of the day, usually because that's when you have the most swelling because you've perhaps been up all day or your legs have been hanging in the dependent position all day. You get swelling when your legs are hanging or when you're standing for long periods of time. You see those varicose veins, the reddish brown staining of the skin, and then you can have scaling of the skin or those eczema changes I mentioned, which is also known as venous stasis dermatitis. So the next wound I'm going to talk about is a diabetic or a neuropathic wound. Diabetics oftentimes have neuropathy, and that is often the cause or the precursor to developing these wounds. Approximately 25% of diabetics will develop a foot ulcer in their lifetime. And this is an old quote, quoting 4 million diabetic foot ulcer cases in the US annually. I would bet that it's much higher at this point. This quote, I believe, is from 2014. The wounds that develop on diabetics and neuropathics are commonly on the toes, the midfoot or the center part of the foot or the heel. They result due to a combination of factors. So typically there's a lack of feeling that is combined with having poor circulation. In addition, there is foot deformity, such as hammer toes or bunions. These rub or are irritated by shoes. and then you develop a wound. The duration of diabetes or how long you've been a diabetic can also increase your chances of developing a diabetic foot ulcer, in addition to your blood sugar. Having uncontrolled blood sugar is also a precursor for developing a diabetic ulcer. This picture here, the diabetic foot, it just really mentions all the things I just went over. So there's a reduction in blood flow. There's damage to the nerves, and ultimately you lose feeling. You develop corns due to hammer toes and deformities, which ultimately rub, and you develop ulcers. A lot of times diabetics have really dry, cracked heels. There are often calluses associated with diabetics because the nerves that are affected also affect the sweat glands to the feet. So you often develop pretty dry skin when you're a diabetic. So the characteristics of a diabetic ulcer, they're usually over pressure points. So it's usually on the heels or the tips of the toes, but it can be anywhere a bone would protrude and rub. They can be pink, pale, they could be dry, but they could also be wet. There are some pictures over here that show classic pictures of diabetic ulcers. Here, they can be partial or full thickness. That's the same with a venous wound. Unlike those arterial wounds, which tend to be full thickness all the way down to bone, these really vary. Oftentimes, they are associated with foot deformity. The signs and symptoms, there's typically a lack of pain. There's typically a period of inflammation that can linger, or you have a period of inflammation that then subsides, and you have more of a stagnant, less swollen and heat-ridden wound. And then oftentimes there is infection associated with diabetic wounds, because there is that component of a decrease in blood flow. There is an increased chance of infection. Signs of infection do include having drainage or discharge, if there's any bad odor, and visibly dead tissue. Finally, I wanted just to mention pressure or decubitus wounds. They affect more than 3 million adults in the US every year. That again is a little bit of an older quote. I would say it could be more at this point. They are caused by too much pressure being applied in one area for a prolonged period of time. This pressure, it causes ischemia, because you can see in this picture, ultimately the pressure pinches the blood flow to the skin between the hard surface, the bony prominence, and the skin and whatever surface the pressure is coming from. If that happens for a prolonged period of time, then that blood flow is cut off, and the tissue ends up dying, and you have tissue loss and a wound develops. Typically, like I said, near a bony prominence, the way that they are assessed is based on a stage system, which goes by the severity of the pressure ulcer. So a stage 1 is known as a non-blanchable erythema. Erythema is redness. Non-blanchable means when you pinch it, you don't get that, just like if you pinch your skin, you don't get that classic white that then turns pink again. You have erythema or pink, red discoloration that's there, that when you touch it, you don't get that white reaction. The skin is intact, so you don't have a visible wound. The overlying skin is intact. The skin is discolored. It can be warm to the touch. You can have swelling. It can be indurated or hardened in the localized area. A stage 2 or a partial thickness pressure ulcer is when you have skin loss. This can vary. If you look at this picture over here, this is showing a stage 1 versus a 2, 3, and 4. And this is showing roughly the layers of our skin. You have the skin, you have fat right below it, then you have muscle, tissue, and bone. And so a partial thickness or a stage 2 ulcer, it can go down to the fat, but it doesn't go through the fat to the underlying muscle. A stage 3 or a full thickness skin loss ulcer is pictured here. So it goes all the way through the skin and the fat layer right below it. It can extend to a layer that's called the fascia, which is a covering over our muscles, tendons, and bones. And it could extend to it, but not through it. If it goes through it to the muscle, the bone, the tendon, then it is known as a stage 4 ulcer. And it is full thickness, but with extensive tissue loss. Then finally, there's what's considered unstageable. An unstageable wound is just like it sounds. You can't stage it. And that's typically because it has a black cap to it, or what we call an eschar. So you can't determine how deep this wound is just by looking at it. And because whenever you see black tissue or dark tissue, you are concerned about a lack of blood flow, you don't ever want to remove the black cap because that can make the wound become more extensive. So you don't just remove the cap so you can determine if it's all the way down to bone, because you can cause more tissue disruption, pardon me, so you consider it unstageable. So moving on to treatment and prevention. Overall, what's the most important is that you identify the type of wound that you have, because then the treatment is going to be dictated. The initial treatment requires identifying it and then classifying it if necessary, and then developing a comprehensive program to address all the comorbidities and risk factors. If you don't address the comorbidities and risk factors, then certainly you're going to have a poor outcome, and that can affect healing overall. The treatment goals vary, as I mentioned, depending on what wound type, but overall, you want to keep the wounds clean and dry. You want to restore blood flow and control edema. You want to treat any infection and offloading, so that's removing pressure from the bony prominences that lead to these wounds. So general wound care measures, I told you guys a couple times, you always want to keep it clean and dry, so no showering wounds. It's something that I'm always talking to patients about, because there is this thought that showering, using antibacterial soaps is good and it's necessary to clean wounds, but especially in the lower extremity, everything in the body washes down. So any bacteria that are on your body, they wash down to those wounds and get in those wounds, and they really make these wounds prone to infection. Changing your dressing is something that should only be done under the guidance of your doctor. If you are ever concerned about a dressing that you have over a wound, maybe you notice what we call strike through or a discoloration to it, you always should call your physician before you remove your dressings, because certain wounds, you could be one, the dressings themselves are specialized and they could be attached to the wound in a certain way or protecting that wound in a certain way. And when you remove it, that in essence destroys that protection that was developed. The other side of it is when you remove your dressing, you're exposing that wound to bacteria and infection. So you only want to do that as prescribed by your doctor. In addition, it's important that all medications that are prescribed to you should be taken as they're prescribed. That's important in wound healing. It's not, and that doesn't necessarily mean medications that you're taking specifically to heal wounds, but let's say, for example, you take the water pill or a medication known as Lasix, you should take that as directed by your physician, because without it, you're going to have a higher tendency to have swelling in your legs, and that's going to affect your wound, you developing wounds and wound healing overall. Drinking plenty of water is very important. That's important for wound healing because it's important for our kidney function. It's also important to maintain a healthy diet. I mentioned protein. Protein is very essential in wound healing. Regular exercise can also be very important, but that's also something that should be directed by your doctor, because in certain circumstances, the more activities you're doing, the more prone wounds are to being disrupted, and that can affect wound healing. And then wearing proper shoes is very important, especially in diabetic patients or patients that don't have good feeling to their feet, or patients that have decreased blood flow. Because if you wear ill-fitting shoes, you're more likely to have rubbing and trauma to bony prominences developing wounds. So treating an acute versus a chronic wound. Acute wounds, if you remember, they heal in a predictable time frame, versus a chronic wound, they don't heal in that 4 to 6 week period. So if you have a clean and minor wound, or even let's say a surgical wound, minimal intervention is often required. Usually just basic dressings are required, and the goal is to keep the site clean and dry so that it can heal adequately. If you had an acute wound that was very severe and contaminated, then it can be necessary to go to the operating room to clean that wound or debride that wound, and antibiotics may be necessary. With a chronic wound, wound bed preparation is really important, which I'll go over. Wound dressings, the specific dressings that you use are important. Footwear is very important. And then managing comorbidities, as well as risk factors, pardon me. With pressure wounds specifically, Even just laying in a mattress, pardon me, can cause a pressure wound to develop. A lot of times people don't understand that just because you think that a mattress is something that's cushioned, but it does provide pressure. And when you are on your back or you're on your side, there are bony prominences. And ultimately, if you remember that picture, that pressure point, which is simply a mattress, it pushes the blood vessels between that surface and the bony prominence, and that decreases blood flow. So something that can be helpful are pressure relieving mattresses and using offloading cushions. In a venous wound, compression therapy is essential. Compression. It is the most important, I would say, when dealing with venous wounds or stasis wounds, because the issue is stasis or fluid that is accumulated. So you want to use compression to help our body get that fluid back where it's supposed to be. Arterial wounds, the most essential and vital in treating an arterial wound is restoration of blood flow. So it's the issue is there's a lack of blood flow, so the treatment is restoring that blood flow. Both venous wounds and arterial wounds can be and should be assessed by a vascular doctor specifically. And sometimes these other wounds also necessitate a vascular intervention or a vascular doctor, but an arterial wound and a venous wound definitely should have a vascular doctor on board. Diabetic wounds, what's most important is addressing the compounding factors. So that lack of blood flow that can be there, and also pressure from having foot deformities. Just like I mentioned, this is just elaborating a little bit on what I was just saying for each wound category here, but in veins or venous wounds, compression therapy is essential. Elevating your legs is really important. Surgical debridements can be necessary, or just debridements within the office themselves. Arterial wounds require a restoration of blood flow and managing any risk factors that patient has. Diabetic wounds require offloading pressure points, and they also require debridements. Pressure wounds require offloading pressure points, reduction of excessive moisture, because moisture, one, it can inhibit wound healing if there's an excess, but also you have shear and friction forces that can cause more trauma to tissue, and then adequate nutrition is very important. So with treatment and prevention, wound care for chronic wounds specifically consists of wound bed preparation. So prevention of these wounds extending also requires wound bed preparation, and then in treating them directly. So the other aspect is using specialized dressings, and that depends on how the wound is looking. That's something that can change weekly, and then offloading. Those main things are important in all the wound types, with the big difference being debriding. Debriding is not something that you would do for all of these wound types. So in wound bed preparation, debriding is not always a factor. Routine follow-up is important, and a comprehensive team is very essential, because I've mentioned a bunch that you want to have a multidisciplinary team, or you want to make sure you're addressing all factors and all comorbidities. So having a comprehensive team, having a team of doctors and medical professionals that can manage all those comorbidities is important, so that you can manage these compacting factors. Serial debridements, or debriding on a routine basis to remove any tissue that is not viable, as well as stimulating new tissue growth, is essential in wound bed preparation, but as I mentioned, is not always part of the wound care process, because with certain wounds, you don't want to debride them because you don't want to make them worse. So wound bed preparation, what that does is it helps create an active environment for healing. There's a picture over here on the side where you can see this physician is holding a blade and removing all of this thick callus tissue. That's important. Before debriding a wound, typically you cleanse the wound as well. There are many different wound cleansers out there. Most commonly, we're using sterile saline or sterile water. There is another wound cleanser known as Dakins, which is a diluted form of bleach, believe it or not, which is therapeutic and also cleanses wounds. And there are many different wound washes out there. I did just want to mention that something that I commonly hear is that patients like to use peroxide. And I think it's important just to note that Peroxide should really only be reserved for when you have a dirty wound or a fresh wound that just happened, because peroxide can actually cause more damage to tissue. And if you continually use peroxide, it can actually inhibit healing and can make these wounds bigger and can make them last a lot longer than they would have. So you only want to use peroxide in certain cases. I've had patients before tell me they use rubbing alcohol. I would not use rubbing alcohol in any circumstance to cleanse a wound because, again, it's what we call caustic to tissue or damaging to tissue. So you wouldn't want to use that. Certainly, you don't want to use just water out of the sink or water from the shower. You want that water to be sterile to help preserve the tissue and prevent infection. After you cleanse the wound, you debride the wound, like I showed you over here. There are two forms of debridement. There's what we call excisional debridement, which is when you remove the bad tissue, which is the tissue you can see here, the thickened callus tissue, but you also take some healthy tissue with it. And that's important because in taking some of the healthy tissue, you're stimulating the wound to heal. When you have a lot of buildup of dead tissue, of callus tissue, of a lot of scab over a wound, that actually inhibits good healthy cells from migrating across that wound to help the wound fill in adequately. So when you remove that tissue, you do enable those cells to migrate for the wound to heal. However, if you don't continue and take a little of the healthy tissue as well, then you're not stimulating that wound to kick it out of that inflammatory phase or whatever phase it's stuck in. When you cause some mild trauma to the wound by taking some of the healthy tissue, you're restarting that wound healing cascade, and that can help stimulate healing overall. Wound bed preparation is essential. It's very important for healing, as well as treating and preventing infection. So when it comes to wound dressings, it does depend on the type of wound, but they are categorized as primary or secondary dressings. So primary dressing goes directly on the wound. So you can think of it as the inner dressing versus a secondary dressing is another layer that you're adding. The goal with dressings is to keep sites clean and covered, but also to help control moisture. So that moisture balance that I mentioned, you want to help control moisture through your dressings. So if you had a wound that was really, really wet and draining, like a venous wound, some of the pressure wounds, then you want to use something that's going to be absorptive to help keep the fluid off of the wound, because the skin around the wound becomes irritated and it can make these wounds grow in size. It can cause pain. And so you really want to control the moisture. That can be done through specialized dressings known as alginates, which absorb, or foam dressings. These are some pictures of some foam dressings on the side there. Wounds that are too dry, which it's not the most common case when you have a wound that's too dry, but an arterial wound, for example, I mentioned it's really dry. It's really that dark black scabbing. Those gangrenous toes or fingers can be very painful. And part of the pain comes from them being so dry and the skin pulling. So you can moisten these wounds with different agents such as gels or ointments. Also, sometimes when wounds get stuck in these chronic phases, they do become very dry. So there are specialized ointments out there that can help with the moisture balance. Another form of dressing, or you can consider this a primary dressing, is what's called negative pressure wound therapy. This therapy is typically used for large wounds, for deep wounds. There are certain criteria that you need to meet to use these wounds, or excuse me, to use these wound care products, but overall they can be a really good tool because it ultimately entails a sponge which fits into the wound, just like on this picture, this black part here. It fits into the crater, the wound that is there, and there's a device with tubing that connects to a machine that creates a constant pressure. Okay, it pulls ultimately or sucks off of the wound. And that creates a constant negative pressure on the wound. And that's very therapeutic because, one, it helps with that moisture balance that I mentioned. It also reduces and kills bacteria because it does create an environment that bacteria don't like. Also, that pressure or that pulling on the wound, it does mechanically assist in the wound closing because it's pulling. And this is at a very low level, but it does stimulate and pull the tissue together mechanically and helps stimulate new blood flow. What is also essential here is pressure relieving devices. So a lot of these wounds I mentioned are caused by bony prominences, by irritation from shoes. And so I just wanted to mention two assistive devices. Aside from wearing proper fitting shoes, or let's say a wide shoe, if you have a wide foot, if you did have a wound, one wound care modality that we often use is a total contact cast. What it is a hard cast. You can see it in this picture, and there is an external boot that is attached to it. So you are able to walk, but the way that the cast is applied is with different offloading pads, which take, in essence, all of the pressure off the wound. So you're walking, but the pressure, there's no pressure directly on the wound, and that enables healing. There's also a specialized insert that goes into shoes called a peg assist, or an offloading insert. This is being folded in half, just so you can see these little pegs here. You basically remove the pegs at the site of where the wound is, and it creates an offloading, a pressure offloading area. And you can put that in specialized shoes, and that also is a good tool to offload. So there is a lot of literature that supports that you should start considering what are called advanced wound care modalities if a wound has not decreased in size, by 50% in a 4-week period. If you have seen no change in a wound in a 4-week period, it's very important to switch course and try something new, because research really has shown us that there is a very poor chance of healing if there is not a 50% reduction in a 4-week period, and that you should change courses at that point. Advanced wound care modalities exist. There are several different things out there. So I'm just going to mention some things here, one of which is biologics. So biologics consist of different tissues and different products, such as platelet-rich plasma, growth factors, and different placental tissues. What they do is they can shorten the inflammatory phase of healing, and that can take a stalled wound into that acute wound phase and help the wound itself progress through the healing cascade in a timely fashion. This is a little blurry, so I apologize, but ultimately, the way that you get PRP, I just wanted to show a picture here, is you draw blood, you take all of the blood in a tube, you spin it down, that separates the platelets and the plasma from the red blood cells. You draw the platelet-rich aspect of this and you inject it. And what that ultimately does is, again, it helps shorten the inflammatory phase. It helps kick wounds back into gear so that they can heal in a timely fashion. Other modalities which are considered advanced are skin grafting and skin substitute grafts. So skin grafts can be partial or full thickness. They are taken from you. So there is always what's called a donor site. So oftentimes, no, I shouldn't say often, but with patients who have other comorbidities or other risk factors, you don't want to go and create another wound, because you can see here this person healed very nicely, but they have this lightened area where the skin graft was taken. That's a large deficit. So if you're worried about, let's say, vascular compromise or lack of blood flow, you certainly wouldn't want to create another wound on a patient. Typically, skin grafts have to be applied in the OR as well. So that's a downside. The positives of a skin graft are it's your own tissue, so it tends to incorporate well, and you get less reactivity. And so that's a benefit of a local skin graft, or a skin graft taken from your own tissue. Then there are different skin graft substitutes. Skin graft substitutes are ones that act as a skin graft, but they're made out of either natural or synthetic products, or a combo thereof. They can be donated human tissue, or they can be animal tissue, or a combination of them. And they can be put on in the office and in the wound care center. In a wound care center, pardon me. They can also be put on in the operating room. So another advanced wound care modality I wanted to mention, which is one that is typically offered by a wound care center or a hospital, is hyperbaric oxygen. So what hyperbaric oxygen therapy is, it's the use of 100% oxygen while you're inside a chamber that has a pressure within it that is higher than our atmospheric pressure, so higher than the pressure that's outside. What this does is it increases the oxygen that's going to the tissues, and that helps decrease edema. It has many indications, but for the sake of this lecture, it is indicated with chronic bone infection. which you can see in any of those wounds, and failed skin flaps, as well as diabetic foot ulcers. In order to qualify for hyperbaric oxygen therapy, you do have to meet certain criteria, which is outlined by different insurance companies, but oftentimes these diagnoses will get you approved. When it comes to a diabetic foot ulcer, it has to be a certain category, a certain depth of ulcer, and other conservative measures had to have been used before you can get approved. So these are just quickly some stats I wanted to throw out here. There are a lot of different articles out there about footwear, and specifically in diabetics, the benefits of footwear. There was this survey that was a survey of diabetics that found that only, 34.9% wore ill-fitting shoes. So that's a pretty high number of patients there. So 35% of people aren't wearing proper fitting shoes. They also found that 12% of those patients had a discrepancy in their shoe size of up to a size and a half. So I thought that was pretty significant. And 90% of patients do not know their shoe width. That I completely see within my practice, and within the wound care practice, which I participate in, that it is very common that patients maybe don't know that there are different widths of shoes. They also don't know their shoe width. Another study actually showed some really positive things in the diabetic population that they were looking at, and they found that 90% of patients were pretty compliant with basic wound care and foot care modalities. However, only 10% wore proper fitting shoes. So that's, pretty significant that 90% of the diabetics in that population weren't wearing proper fitting shoes. And it's so significant because most diabetic ulcers are caused by rubbing in shoe gear or just having too much pressure due to shoes, or could be a lack of shoes, but due to shoes on your feet. So wearing the proper fitting shoes is really a key preventative measure. Furthermore, in preventing issues and preventing these comorbidities, these risk factors from worsening or from having these, and also in the treatment of wounds, it's really important to follow regularly with your physicians, and that can be a team of physicians. It's important to follow regularly with your primary care doctor, your endocrinologist, if you have endocrine on board, nephrology, cardiology. It's very important to follow with the vascular doctor, especially if blood flow is part of the problem. Vascular is essential in helping restore that blood flow, and also in vein wounds and venous disease. It's important and essential to improve circulation. So that's twofold. That's the blood flow going down to the limb and the blood flow going up. So use of compression is essential, especially when you have any venous varicose veins or vein disease. It's really important to wear compression as a preventative as well. Anybody who stands in a job or is in a job where they stand on their feet all day, compression can really be a preventative measure to prevent varicose veins, and ultimately, if you have varicose veins, to prevent ulcers from developing. This is that picture where it shows the veins, how when you have varicose veins, you have the flow going both ways instead of one way. And when you wear compression, how it assists and adds extra pressure, so that enables the flow to go in the right direction. And then up here, this is just a picture showing diabetic foot screening. This is a special tool called a Semmes-Weinstein monofilament, and it's a small monofilament, and you use that to test a patient's feeling, to test a sensation known as our protective sensation, or our body's ability to protect itself. And this is essential in helping diagnose diabetic neuropathy and ultimately in instituting preventative measures. So offloading bony prominences, that's with proper fitting shoes. That's with the offloading mattresses that I mentioned. There are different offloading pads and pillows that can be used as preventative treatment and control of comorbidities. So your blood sugar being out of control, your blood sugar being elevated is definitely a factor that can decrease wound healing. You really want to have your hemoglobin A1C at less than 7%. Your blood pressure around 130/80, and kidney function is essential as well, especially in fluid control and edema control. Lifestyle changes are also important in prevention as well as treatment. So exercise if directed by your doctor, weight loss or gain in cases when you have a malnourished patient, and diet are important. So monitoring your salt and your sugar intake is very important. So that was it. I wanted to conclude just by saying that it doesn't matter how long you've had a wound. If it's acute or chronic, you should be treated with a comprehensive plan. And what that means is having a timely diagnosis, following with your doctor regularly, and with a team of doctors when needed. The best way to prevent is to control those risk factors, and following up, as I just said, with your doctor regularly is really important, especially a multidisciplinary team approach. So today was really an opportunity just for me to give you an overview of these wounds, and I look forward to in the future elaborating a little bit more on dressings and the different treatments for specific wounds themselves, and maybe going into a little more detail in the future just about different skin flaps and other advanced treatments too. But I really want to thank you guys for your attention today, for tuning in. I'm always really congratulating or rewarding patients, rather, I think is what I want to say, just for, taking their care into their own hands and, wanting to be educated. So I always appreciate, everybody participating and coming, and I warrant any questions anybody has at this time. So the question is, when deciding on a dressing, do you ever consider how the dressing's antimicrobial properties could lead to bacterial resistance within a chronic wound? So that's interesting. That's an interesting question. I think it is something that is somewhat considered. A lot of the dressings that are out there, so if we're talking about a primary versus a secondary dressing first, I'll say that there are basic dressings out there that have antimicrobial properties such as silver or different dyes and different things in them that are antimicrobial. As far as my background and my experience, there isn't a lot of literature that says that bacterial resistance develops with those basic modalities of silver and different dyes that are used that are antimicrobial. Then there are different ointments and also antibiotic ointment, for example, that are used within dressings. And that is definitely something that I consider. I don't ever use antibiotic ointments unless it's necessary because of developing bacterial resistance. That's the same with taking oral antibiotics as well. A lot of wounds have characteristics that can look infected, like in stasis wounds, for example. They can be very red, surrounded by a lot of red tissue. They can be very irritated. So it really does take a specialist to be able to differentiate, is this infected or is it not? Because you shouldn't just use antimicrobial dressings or antimicrobial agents such as antibiotics because you can get bacterial resistance. So I hope that answered your question.
Hi, Dr. Collins. It looks like you have answered all the questions. Thank you for taking the time to present. If anyone does have any further questions, you can email me at programs@mbortho.com. I will then consult with Dr. Collins and get back to you and get your question answered. If you would
There's
like
one question.
Oh, there's another?
Yes, if you want me to answer it real quick.
Oh, of course. Go ahead.
So somebody just asked, with a minor wound like a shallow cut or a puncture, is it better to leave it open to air or cover it with the bandage? So typically it's better to keep it covered just because that in essence prevents bacteria from getting into it, and it creates usually a moist wound environment that allows healing. So if you had to, there are so many factors that come into play here, but if you had to in a pinch, should I cover it? Should I not cover it? I would definitely say cover it. Definitely cover it. If you had a dry scab, that's fine to be left open to air, but again, it just depends on the wound. The safest bet is to keep it covered. So that's it.
Okay, I'm back. So if anyone has any additional questions, go ahead and let me know, and by emailing me at programs@mbortho.com. If you'd like to schedule an appointment with Dr. Collins, please call the number on the screen, which is 855-896-0444, or you can go to our website at www.mbortho.com. Again, thank you, Dr. Collins, for the information. It was a really good presentation, and we all appreciate it. To everyone else, enjoy the rest of your afternoon. We'll see you next time.